Good afternoon and welcome to this premier webcast, Getting to Zero. I am Anuradha Gupta, the President of Global Immunization at the Sabin Vaccine Institute. And at Sabin, we work to expand access to immunization, spur innovation and local solutions, bolster agency and voices of communities, and ensure no one remains unprotected with the power of vaccines. The purpose of the webcast is to explore fresh ideas and best practices that can take the world closer to zero in terms of deaths that vaccines can help prevent. And I'm so delighted that for today's webcast, we have with us my friend, Dr. Ephrem Lemango, who's the Associate Director in charge of immunization at UNICEF. Only last week, UNICEF released its report, The State of World's Children, very focused on immunization, that brings us very sobering news and insights. In 2019, prior to the pandemic, 19 million children in the world were only partially vaccinated. Out of these 19 million children, 14 million children were absolutely zero dose, having received no routine immunization at all. After the pandemic hit in 2020, the number of zero dose children rose to 16 million. And in the next year, in 2021, it rose to 18 million additional zero dose children. So, over a 3-year period, from 2019 to 2021, the world has accumulated 48 million zero dose children who remain completely defenseless against virulent diseases. Another 19 million children have only been partially vaccinated. And as a result, we see a resurgence of diseases, large and disruptive outbreaks of measles, diphtheria, polio, yellow fever. So let me now turn to Dr. Ephrem, welcome him. And Dr. Ephrem, we would really want to have you share with us some of your key insights and perspectives on some of the challenges that the report has highlighted. So my first question is, what are the 3 top barriers to immunization today? What are the approaches that are needed? And do you see these barriers as permanent or surmountable?
Thank you very much, Anuradha, and I really appreciate you inviting me to your first webcast. And it's at the right time where we have an opportunity to shed lights on the key issues in immunization. As you stated, the State of the World Children launched last week heavily focuses on 3 important issues, which relates to the issue of getting to zero. We're very optimistic that getting to zero is very possible, but it requires a significant political commitment and determination from governments, partners, and health workers. In the report, we shed lights on 3 important things, and this relates to also the barriers that you are asking about. Number 1, we state that there is a significant number of children that remain unreached. Between 2019 and 2021, 67 million children are either completely or partially missing their routine immunization. And 48 million of them are zero-dose children. And this doesn't even factor the number of children we may have missed in 2022. So there is, in fact, over 67 million children that we will need to reach. And this should happen before it is too late, so that we would avert expansion of these vaccine-preventable disease outbreaks that are happening in different countries. And the second message is that there are some alarming signs that we will need to find ways of dealing with. And primarily, it's vaccine confidence. Based on our analysis, there might be signs of declining confidence in immunization that requires us to find ways of understanding what promotes that and find ways of acting on it. The third and most important is, even though we're talking about COVID-19 related disruptions causing access limitations in immunization and disruption in immunization services, we're also honoring the fact that there are also pre-existing challenges primary healthcare system strengthening limitations that we have seen that are limiting access to vaccination. There were issues of deprivation, there were issues of inequity, primary healthcare services not being available to remote rural communities, pastoral communities remains a challenge. So it really specifies these three major challenges and calls for governments to take action in this very important time before it is too late. And this takes me to the question of the barriers. And I actually think, and UNICEF believes, these barriers are not insurmountable. We can find ways of dealing with them. Number one that we have to really work on is improving vaccine acceptance. Communities tend to take vaccines when they have a full trust in the system that delivers vaccines, when they have a good understanding of the value of vaccines, and when there is lesser risk of taking vaccine than not taking. And our efforts will need to be to really use all available avenues, particularly engaging with communities, devising methods for listening to social dynamics, issues that are raised by communities, and really work with health workers, given there is no any substitute to the interaction between a health worker and a provider. The second would be is the need to really find ways of averting access-related limitations. If you see in the report, we talk about the issues of poverty. The wealthiest percentile, the wealthiest people have more access to immunization when you compare it with the poorest ones. In some countries, it goes even as high as 10 to 20 times more likely to be vaccinated if you are rich than if you are poor. And location also really matters. Rural communities are less served as compared to urban communities. And we have also seen significant limitation with gender-related barriers, where given mothers are the caretakers and they are the one responsible in many of the communities and countries we work in to take their kids and have vaccinated. Anything that limits their access to education, anything that limits their level of empowerment does have an impact in making sure their last child is reached. So overall, this report emphasizes the need to really find ways of bridging this access challenge, especially in remote rural, conflict-affected settings, and even in urban poor areas. And finally is the vaccine financing component, overall immunization financing, overall primary healthcare financing, which seem to be the critical limitation now we are in, especially low and middle income countries who have been impacted by the pandemic and the disruption it has caused are likely to feel and see much fiscal pressure going forward, despite their intent to be able to invest in primary healthcare. So our call for governments is, despite its difficulty, despite the limitation, still investing on immunization in primary healthcare will have the highest return on investment, and it is likely to lead to empowerment of communities and strengthening of systems and really spurring economic growth.
So thank you, Ephrem. So let's dig a bit deeper into some of the aspects that you have highlighted. So one relates to pre-existing and continued or more exacerbated health inequities. Global institutions have come together only last week to call for the big catch up. So my question is, how are we going to make sure in resource constrained settings that these catch up campaigns and exercises actually focus much more on under vaccinated and unvaccinated children who are the epicenter of increased disease and disease outbreaks? And how do we make sure that these campaigns pave the way for more sustainable service delivery models that are able to regularly reach those children who are being currently missed both by routine immunization services and campaigns that are run from time to time?
Right, and Anuradha, that's a very important question. And the big catch-up campaign, it is an effort to build back immunity. Our current limitation is we have millions of children that remain unvaccinated, and there is considerable immunity gap that we have to bridge. And to do that, we are announcing the big catch-up campaign, which is an effort to encourage countries with high number of zero-dose children to be able to plan and reach these children that are missed. But it's not only reaching the missed children, but it's also restoring services that have been disrupted. Because we see in so many countries, there still continues to be disruption of essential health services that was originally caused by the pandemic. And our recent reports show that up to 50% of countries still report some form of disruption. And the third component of this big catch up beyond reaching the missed children and beyond restoring is strengthening systems. So we are aiming to reach and support 20 countries who have some 75% of the zero dose children, for them to take considerable action in identifying the zero dose children, in identifying these under immunized ones, and then deploying the right set of mechanisms and service approaches for them to be able to reach these children, but to also reach those communities sustainably so that the next cohorts and the following cohorts of children will be able to be sustainably reached. And we have seen good examples from different countries. One good example is India, and where they have increased the number of stations where vaccination is provided and the number of sessions that they used to provide per week, which basically is used to reach more children and to catch up on those children that have been missed, who are currently older than 2 year old. Most of them are between 2 years old and 5 year old ages. So we want to make sure that these new sessions, additional sessions and additional stations that are used to provide vaccination services are also going to continue to reach more zero dose children. It does require investment because it has a health worker component. Given health workers will need to be supported and they will need to be able to find ways of reaching these zero dose children, but also even strengthening supply chain systems would be quite critical if you are to avail vaccines to this last mile. So the same is what is being planned in places like Nigeria, where they are planning a zero dose approach to targeting on 100 LGS or local governance areas that have high number of zero dose children, and aim to reach address the zero dose children within a period of 2 years period. And the intention is they catch up on those children that they have missed, but also strengthen systems to reach those new cohorts that are going to come. Okay.
So, Ephrem, you really highlighted India and Nigeria. India and Nigeria actually are the countries with the highest number of zero dose children. So, it's great to see these efforts underway. But if we look at Africa, we also see that Africa would continue to have high birth rates for several years to come. And also, in terms of health workforce shortage projections, Africa is projected to continue to suffer from very large, in fact, the largest workforce deficits. How do you see this getting resolved in order to provide basic health care, including immunization services, to populations that are currently not receiving them?
So governments at this very moment have a hard task of choosing what to prioritize, especially amidst of fiscal stress. And if we are to reach children in the African continent, and the entire Africa is home to half of the unvaccinated and the zero dose children that we are speaking about, and we cannot achieve anything unless and otherwise we are able to support these countries and governments taking a significant role in reaching zero dose children. And the health workforce is one of the critical aspects at this very moment that is playing, I would say, in immunization, women health workers are the largest vaccinators. But what we have at this very moment is that these health workers are not supported, are not well skilled, and are not salaried. And if we are to reach the last child, we will need to find ways of supporting these female frontline health workers. We'll need to find ways of skilling them. And despite fiscal difficulties, we will need to find ways of compensating them. Salary is the very basic essence of all this work, because we estimate in Africa we have about 1 million community health workers. But what is needed is about 3 million community health workers. And I'm talking about community health workers because that, I think, is the best way to reach the last mile, in addition to working on nurses, midwives, and physicians. But the key challenge would be in this increasing number of community health workers is, one, to train them through a very good curricula that is able to address not only vaccination or specific vertical diseases, but overall engagement in maternal and child health, in communicable and non-communicable diseases. Second is to make sure that they are compensated and salaried, which requires governments to allocate funding for them. And of course, at the end of the day, these community health workers would only succeed if they have the right sites to work in, and they are supported through supervision and monitoring. They are supplied with the right equipment, and they are part of the overall primary healthcare system in countries. So it is a very difficult choice that governments have to make, but healthcare, it's not a drain to resources as most governments would see. Healthcare is an investment. It creates opportunities, it creates jobs, it creates economic growth, it does spur growth in countries. So we want to make sure governments are also able to understand this as an investment rather than a drain to very limited resources they have.
Very well said, Ephrem. And all of us know that every $1 invested in vaccines fetches a return of $52 in long term productivity, which includes improved learning outcomes for children and reduction of out of pocket catastrophic medical expenditures. So you highlighted the gender dimension of the health workforce and how more than 70% of the health workforce in countries is female workforce, and the kind of difficulties, discrimination, and neglect that they suffer from. But if we really broaden this conversation to focus on gender related barriers that caregivers suffer. And we know that in most low and middle income countries, it is mothers who shoulder the disproportionate burden of child care and the responsibility of bringing the children for immunization services. And if we really want to tackle the issue of zero dose children, then it is important to start to address those gender related barriers. So, would you share with us some inspiring examples of how countries are now showing new thinking in terms of identifying and resolving some of these common gender related barriers?
Right, you are, Anuradha, and this is the most important topic if we are to make a dent on the zero dose issue. Gender play a significant role, and mainly it's a major driver, and it's a major setback as well, given most of our health system doesn't necessarily recognize these key issues. And it requires us to shift from this perspective of gender mainstreaming, gender responsiveness, to truly becoming gender transformative in a way that we design and position systems to be able to respond to these barriers. I'm going to give you an example. In many places, we understand women are the caretakers. Women are the ones who actually take their kids to vaccination. But women are also responsible for many other chores in-house and out of the house. And most of the women, especially in urban areas, you see them that they are urban dwellers to be able to find a means to put food on the table for their families. So when you ask them to come for a vaccination, it means that they have to forego this. So there is an opportunity cost that comes with having a child vaccinated. So when they find, even when they even manage to do that, and when they come to the facility and they find the facility closed or there is no vaccine, then that's one issue that we really need to keep in mind. And another aspect of it is that most of vaccination services provided in regular working hours, which is not convenient for many urban dwellers and women in there. So we have seen good examples during COVID-19 vaccination where several countries introduced this moonlighting, which they open vaccination sites quite for a longer period of time, including evenings, opening during weekends, etc., has really enabled us to do things differently. And when we are reaching communities, for example, door to door, in some urban areas, you see these, several these apartments and condos where it's very hard to find each child going door to door, which may require us to think, okay, we have to think about going floor to floor to really convince communities who have this challenge. And there are also barriers that pertains to, women being also health providers. Huh? They are the ones responsible. And we know the health system is vaccines are provided by women, but health is led by men. So the process of really bringing women to a leadership position really matters. And we have also seen when women are empowered and when women are educated, the likelihood of their children being zero dose is quite low. So there is already adequate evidence to support that working on gender is a means to actually to get to the last child. It's a means to get to having zero vaccine preventable diseases. And these are some of the examples where through our, for example, in UNICEF, through our human-centered design, we really work with communities to understand these gender barriers. And we also do gender barrier analysis to really make sure systems are designed in response to this. We have seen in some communities where male health workers are not welcome to households, changing that to female health workers playing that role have really increased vaccine acceptance. So it is all in all to establish systems to understand what the community thinks, what are the key issues that affects gender and or that are fueled by gender related barriers, and then it's to address those. And we have good examples to be able to do that.
So you're right that a lot of work lies ahead to unpack and resolve gender-related barriers, and looking at a spectrum of interventions that are gender responsive to gender transformative. And it is about healthcare providers, it's about mothers, but also it is about lack of participation of men in childcare responsibilities in several areas, but also women in leadership in global health and public health space. So coming to women related issues and their health, Ephraim, HPV is one shining example of a vaccine which is highly effective. And this vaccine can actually prevent cervical cancer and related deaths. We know there are 600,000 new infections every year, and 340,000 women die every year because of cervical cancer. And despite the solution being available, we today are faced with a situation where the global coverage of HPV vaccine is just 12%. It has come down from 15% to 12%. So my question to you is that what are the steps that are needed to advance life course immunization that includes vaccines like HPV, COVID-19 vaccines, and several others that are beyond the traditional window of childhood vaccines, but also how do we accelerate the uptake of a highly effective vaccine like HPV?
You're raising a very important question, Anuradha, particularly in HPV and the life course vaccination efforts we have in different countries. The pandemic affected the coverage of HPV vaccination from 15% to 12%. So it tells two stories. One, obviously, the pandemic impacted the overall coverage, but we were also on a very low level of coverage before even the pandemic, which requires us an intensified effort. Currently, the members of the Gavi Alliance, UNICEF, WHO, donors, and partners are working to scale up and relaunch HPV vaccination introduction in several countries. So there is an effort over the next 2 to 3 years period to be able to reach additional 46 million girls, in addition to the 40 million girls we are reaching in Gavi eligible countries. And this requires us to do some of our approaches, to change some of our approaches in general. One, the main deterrent so far has always been vaccine supply, and that seemed to be now resolved, given that we have also a guidance that allow to use only one dose of HPV vaccine, which is equivalently protective as 2 doses. So it really helps governments to be able to roll it out immediately and be able to provide only one shot of vaccine that helps young girls to protect or to prevent the occurrence of HPV in general. The second is, so far we have been only focusing on one age group between the 9 to 14, and due to the supply shortage, we're focusing on only the age group that leaves this bracket. Now we have an opportunity to expand for the 9 to 14, which makes it multi-age, and it's an opportunity now. And also an opportunity to catch up on those that we may have missed over the past few years. But this will require us, one, to think out of the box, particularly so far the effort has been school focused. And when the pandemic hit and schools closed, we couldn't provide HPV vaccination. So we need to expand to go beyond schools. And this also requires us, as we expand the age as well, there is high dropout from schools where many young girls are either married early, or they drop out from school for many other reasons. So it requires our health services to go beyond the usual systems to reach these young girls. And HPV is only one entry point because it requires us also to think beyond HPV and consider reproductive health services that are needed by adolescent girls and overall health services to be provided. So there is an opportunity and there is a challenge. But we have seen from COVID 19 providing vaccines to a very different age group, the likes of adults, would also need us as immunization partners to to really help governments to be able to structure their immunization program to have a broader scope. So far, immunization program has always been child focused, under 5, but now it is time that it widens its purview. Still remains EPI, but it widens its purview to also include vaccines for adolescents, adults, older age population, and then forms the basis for life course vaccination.
Thank you, Ephraim. I wish we could carry on, but all good things have to come to an end. So let me get to my final question. That during COVID-19 pandemic, as the report rightly highlights, and you also reinforce that point, we have seen skepticism about vaccines increasing. So, what do you think are some of the simple ways of improving public sentiment and also some of the negative perceptions that we're seeing about vaccines and immunization?
Right. In the State of the World Children report, vaccine confidence is one of the issues that we have featured considerably in the report. And rightly so, because we are seeing some signs of declining vaccine confidence. There are ways to deal with it, and it starts by understanding what motivates people to be vaccinated. And parents decide to have their kids vaccinated first by understanding the use of vaccines and the value of vaccines. And we know vaccines are the miraculous discoveries of humankind that have been able to save humankind from suffering and death. And but beyond that, it also, a parent will need to see the risk and the benefit. And sometimes you feel very complacent as a parent to say, "Oh, things will be fine. I don't really have to have my child vaccinated." And you prioritize other household chores and responsibilities that rather than having your kids vaccinated. But overall, it is based on your trust to the system. And it's not only about even the vaccines, it's the trust you have towards the overall primary health care, the trust to the institutions that make the vaccine, that buys the vaccine, and the trust to the governments that actually offer those services. So it is all these things that come together that we really need to address when we are trying to improve vaccine confidence in general. There are ways we can do it. One is to engage communities. We have seen there is adequate evidence that the more you engage communities in design, planning, and implementation of vaccine-related interventions, the vaccine confidence and trust improves. And social listening is another modality where we build systems to really understand what is driving vaccine confidence, what are the factors that contribute to vaccine acceptance in communities, both through social media and regular media. Then we try to design our services accordingly. And finally, is really working on interpersonal communication of health workers. In many places that I have traveled through and that I have spoken to communities, the first question that mothers always ask is, what is the side effect of this vaccine? And no health worker have told me. So the moment she sees a fever, the moment she sees a bit of headache or some sort of behavioral change in her child, a woman would decide, oh my goodness, this is not what I want. But if a health worker take time to actually inform the mother or the parents to be able to respond whenever this, side effects or adverse events happen, then the mother would be prepared, and additional medications and so can be provided as part of that consultation. So the interpersonal communication will really need to improve. And finally is really the gender aspect of this. And gender meant is not only female, but it's also the male. And in many communities, and there are enough examples, for example, in Ethiopia, where we have seen when a woman is empowered to make a decision, we have seen this in other countries, empowered to make a decision, the likelihood of a child being vaccinated is higher. And especially when the men are also engaged and both make the decision, the likelihood of a child being under immunized or zero dose significantly decreases. So both men and women, both parents have a role to play, and it's their joint responsibilities. And it's not something that we leave to the woman. But at the end of the day, given we understand how communities are structured, we want to make sure barriers for access are heavily considering the key issues that women actually face. Oh,
Thank you so much, Ephrem, for bringing this message of hope and optimism to our audience. Can do attitude. Yes, there are problems, but we also have solutions in sight. I always believe in one saying, when the going gets tough, the tough get
yeah.
going. So we all have to brace ourselves up to really take some of the challenges that we are seeing in immunization space heads on. So thank you all very much for joining this conversation. Watch this space closely. Those of you who are interested in vaccine acceptance and demand issues, you are most welcome to join us for the VAN conference, Vaccine Acceptance Research Network Conference, where both Ephraim and I would be delivering the opening keynote address in June. But we would also take that opportunity to benefit from the insights of practitioners, decision makers, community mobilizers, advocates, and researchers. So you will have a QR code appearing on your screen shortly. Join us, and we look forward to seeing you in Bangkok. Thank you, Ephraim. Thank you so much for joining us, and thank you, audience.
Thank you so much, Anuradha.